Hello, welcome, welcome. I see some folks trickling in. Welcome, everybody. I know that you might be muted, and that's okay. I see we've got about 8 folks already in the I guess the chat, or what's it called, attendee list here. So welcome, guys. We're going to get started in about 1 minute. I appreciate you guys being on time today. We're going to start promptly at the top of the hour. If you guys could do me a favor to kind of check in, so to speak, if you could type in your first and last name, since some of you don't have names attached to your user IDs in the participant list, just type in your first and last name in the chat box for me so that it's almost like a roll call, so I know who's attending today. Hi, Anne. Thank you.
Kristen, you want me to put up the slides so they can do the pre-test?
Yeah, one moment, Mark.
Okay.
I'm gonna do it 1 second. You can go ahead and share that landing page, Mark, with the first page of the module.
Yeah, that's what.
Hello, thank you. Hi, Margaret. Hi, Sheila. Hi, Guadalupe. For those who are just joining, I'm just asking that if you can just sign in, so to speak, in the chat box, first and last name, just so I know who's joining us today, since some of the names are kind of shorthand or whatnot. Okay, so we're going to go ahead and get started. We might have some, excuse me, some late attendees, but that's okay. So welcome. Hi, everybody. My name is Dr. Kristen McGill. I am the project manager for the NADD's Dual Diagnosis Training Project. We thank you all for taking time out of your day to participate today. As you guys know, today's session is relating to kind of an overview of crisis within the IDD world. So we'll be going over some very important topics over the next 2 hours to really get you guys prepped and ready for crisis and crisis response, prevention, and intervention. To get started here, I just have a couple logistics items I want to go over just to make sure you guys know what to do and all that kind of stuff. As you've probably noticed, you all are muted at this point. And that's just so that our trainers, Doctors Mark and Celeste Harvey, can, when they start talking and stuff, we don't have any outside or background interference. If you guys do have any questions or comments during the training, we ask that you use the chat box. It'll be monitored throughout our session today, and we'll be responding, either myself or one of our trainers who, while they're not sharing, will be responding to any questions you might have. Excuse me, at the end of the session today, or I'm sorry, as part of the session today, we have a pre-test, which is kind of a preliminary, get you ready, see where you are, see what you know about crisis overview. So I'm going to go ahead and put a link to that pre-test in the chat right now. I ask that you guys go ahead and click on that, fill it out really quickly. It's only about 5 questions, very simple, multiple choice, nothing stressful. Go ahead and take a minute, fill that out. And then we will get started here momentarily. If for whatever reason during the training today you have any type of audio or technical issues where you get kicked off or you have to sign off and sign back on, that's fine. I'll let you back in. Don't worry, don't stress. You'll still get credit for participating today. And again, as I said, any questions you have, please throw them in the chat box. So thank you and welcome. I'm going to turn it over to our trainers, Dr. Celeste and Mark Harvey, to introduce themselves, and then we'll get started.
Hi, everyone. I'm Celeste Harvey. I'm an associate professor of behavior analysis at the Chicago School in Dallas, and I've worked with the National Association for the Dually Diagnosed for approximately 5 years on various projects. I have over 30 years of experience working with children through adults in a variety of community and clinic settings. So I hope to be able to learn from your experiences and also share from the experiences that I've had.
And just a quick check, so you guys can see the slides, right? With the,
Yes.
Okay, just want to make sure. Okay, welcome. My name is Mark Harvey. I am, well, I've been working with NADD for about 4 years now, and I'm really kind of excited to be working with individuals with developmental disabilities who also have some mental health needs. I've been noticing it a lot. I work with many of the schools. I've been working with parents as well, and with APT as a provider as well. My background is in special education. I've been working with individuals who have developmental disabilities for approximately 35 years. And yeah, that shows my age. And I've gone everywhere from working with the little ones that are about, I think the youngest I had was 2 years old, and the oldest I had was about 78. And so I've kind of gone across the spectrum. I've met many folks who have severe disabilities. And one of the things that I'm going to try to get across today is kind of the differentiation between behavioral issues and when we get into crisis. Because some of the folks I've worked with have been highly aggressive, have engaged in self-injury, have been aggressive towards myself. I've had television thrown at me. I've had people bite me, kick me, spit at me. But I considered that a behavioral issue, not necessarily a crisis. And so we want to get into, well, what's the difference between behavioral issues and crisis issues? But before we get started on that, I want to make sure you have the QR code there. I think it was also put in the chat. So if you do the pre-test, again, you're not being graded on this. There is no failing. It's just one of those things where we kind of see where you are baseline wise, and then we're going to see at the end if maybe we've taught you something. And if we haven't, then it's on us. And along those same lines, this project was provided or was supported in part by the Florida Developmental Disabilities Council, the FDVC, who had a grant through ACL in the Department of Health and Human Services. If you like what we say in this presentation or any of the other presentations that we do, please give them a shout out. Thank them for supporting our work. If you don't like what we say or what you hear, that blame comes back on us. That comes back on me. That is, these are my opinions. These are my presentations. So, but we do really appreciate them funding us and helping us support some of the stuff that we're doing. So please give them a shout out if you get the chance. Let them know we appreciate it and that you learned something. That's kind of what our goal is today. So with that, there we go. We want to also note that some of the eligibility requirements that are there are going to change by state. We are going to specifically talk about Florida. I'm in Florida. I've been working in Florida for almost 20 years now. So it's going to be very specific to Florida, but eligibility requirements, the definitions may change a little bit if you go across different states, and actually may even change within regions here in Florida. So just have that as a note. If you have any questions about that, there should be a resource list, or you can contact someone at APD or FDVC or anyone at NADD. We would be happy to help you and talk about some of those changes or some of those differences that you've noted. So within this first of the 4 series, what we're going to talk about is, first, we're going to define what crisis is, what it looks like. We come from a behavioral background, and so for us, it really is going to come down to more overt behaviors, what you're seeing. And we like that in that we can get agreement between people. Sometimes it's hard to get agreement between what people are feeling on the inside. And in fact, that's one of the issues that we've run into when we start talking about crises, is that our perception from the outside doesn't always match the perception of the person that's in the middle of the crisis. And so we're going to come from a behavioral perspective on that and kind of give you a good definition of what a crisis is. Do note that crisis is going to be individualized. It's going to depend on the people you're working with, on the cultural factors that are there, on the parents, on all those systems of support that you have there. So we're going to kind of give you a general overview, but it can't be specific for the people that you're working with. So we're going to give you some guidelines and some things that you can do, some tools that you can use. But what we're hoping you do is you take those tools and you individualize what the assessments look like, what the interventions look like based on the people that you are actually interacting with or you're supporting. It may be a loved one that you're supporting as well. So we're going to talk about risk factors. What are some of the things that put individuals at risk when they have intellectual developmental disabilities, IDD? What puts them at risk for any kind of mental behavioral health crisis? We're going to get in, explain why people with IDD and mental health are more vulnerable to crisis. And our approach is going to be a biopsychosocial framework. We're going to talk about some biological issues that come into it, some of the psychological issues that come into it, and again, the interactions, the socialization of it that's there, and some of that behavioral background as well. So from this, we're hoping that we can describe 3 stages of crisis, and this is the first of the 4. So the next 3 are going to actually be part of those 3 stages of crisis, which is pre-crisis, during the crisis, and then once the crisis is over or post-crisis, what you can do. So this first one is a broad overview, right? We're going to talk about those, but we're going to give you specific strategies for how to deal with certain things that are happening during the pre-crisis phase, during the crisis phase, and during the post-crisis in the subsequent presentations that we're going to do. So our roadmap, that is what we're going to try to do here, is we're going to cover values, because the values that we're talking about are the foundation for this course, right? What are the values of the client? What are the values of the people who support them, of the loved ones that are there and around them? We're going to go back to that definition of what a crisis is. We're going to talk a little bit about risk factors, right? What put people at risk for a mental or behavioral health crisis. We're going to talk about triggers. And again, this is going to be the general overview. Triggers are really going to be covered in depth when we get into that next one, which is on the pre-crisis. So they can talk about what are specific triggers for the individuals that you work with or support. So going over why people with IDD and concurrent mental health issues are more vulnerable to crisis using that biopsychosocial approach. So through this, what we're hoping is you understand the stages of crisis. And then at the end, we're going to give you a summary, a preview of what's coming up. And at the same time, provide you with some references just so you know that what we're talking about is really evidence-based practice. We're going through what works for other folks. And again, those general, here's what's going to happen. I do want to add one more caveat in this because I can hear thunder. If I lose electricity, I'm hoping Celeste can jump in and take over, just because you never know in the state of Florida what the weather's going to be like, and it can change the next 5 to 10 minutes. So with our roadmap, one of the things that we want to start off with, and hopefully we're going to do this every single time, is to let you know what, when we're talking about crisis, when we're talking about mental health crisis, behavioral crisis, this is a sensitive issue for many people. If you've been through a crisis, if you have been traumatized by it, it can really trigger feelings in yourself. So if you're doing that, what we're hoping you do is that you actually monitor yourself. Make sure you know what your stress level is. And if you need to, stop. You can turn this off. You can put it on pause. You can step away for a minute, right? Text someone, whether it's a peer, a friend, a mentor, maybe a relative, right? Out there. Or for me, and I think this probably holds true for Celeste as well, I've got my dog. And usually they're here behind me, but that may be a little disruptive. So we're going to have them downstairs. But I always know I can always stop things. I can go downstairs and I can get a good cuddle from my dog. For me, listening to calming music helps as well. And it reminds me to breathe. And one of the interventions that we're going to talk about later is actually box breathing. And that is, how do you use mindfulness? How do you get into a state where you're actually can start to relax? Because when we're talking about crises, this can actually trigger a crisis within yourself. So please, please, please monitor yourself, stop, take a break as needed. and then come back. Our public service announcement for the day. We're going to start in with why people with IDD, intellectual developmental disabilities, and mental health are vulnerable to crises. To do that, we really want to start off with the definition of what is intellectual developmental disabilities. Developmental disabilities is this spectrum, this diverse group of chronic conditions that can be attributed to either cognitive disabilities or physical impairments or a combination thereof. So intellectual disabilities in and of itself generally is based on cognition and the cognition levels. So you may hear people talk about IQ scores, and that's where this puts them as having an intellectual disability. Down syndrome is one that comes in with trisomy, right? And so with Down syndrome, you may see some physical attributes that are there, same with Fragile X and cerebral palsy. Cerebral palsy, for many folks, they are left or right side affected, and that side does not show the same muscle tone as the other side. So this bigger group includes all of intellectual developmental disabilities. The primary one that a lot of folks are talking about because of the prevalence is autism spectrum disorder. Autism spectrum disorder is included within the definition of intellectual developmental disabilities because it does generally start before the age of 18. I've had some folks that I had worked with before because one of the other ones was a traumatic brain injury. If someone gets hit in the head and they have an intellectual disability where they have a cognitive disability, if it happens prior to the age of 18, they may be considered as having an intellectual disability. If it happens after the age of 18, many people would say, well, that's a traumatic brain injury. That's a TBI, and that's different. So again, developmental disabilities happen prior to the age of 18. And for the most part, they may need some lifelong supports. At the same time, what we're hoping is you guys get so good at this that the supports that they're going to need are minimized, because that's really where we want to get. We want to get you to a point where you can say, I can support them, but they don't need me as much as they did before. So going back with that disability categorization, within that, generally there are some issues with language, communication, right? There may be some mobility issues, that is in the gait, in the way people can walk about. And in fact, we run into this many times where individuals who don't know about intellectual development disabilities, haven't learned about it, may see someone who has a mobility issue, right? In this case, we had someone who had autism spectrum disorders, they had ASD, they had a mobility issue where they weren't walking in a straight line. The police had stopped, they had gone over, they wanted to talk to the person. In fact, he was nonverbal, or the speech that he was producing was not coherent. Some people didn't do it, and a lot of folks just assumed that he was under drugs or he was on drugs. So a lot of these physical disabilities can come out, and people who don't know what intellectual developmental disabilities are about may say, I see this as something else. So we're hoping that you can help us educate other folks that are out there. Folks may need help with learning and different strategies. They may need help with self-help, right? Those activities of daily living. And the idea is that we want to get them to a point where they can actually live independently. They can start to make their own choices. So that's kind of our review for intellectual developmental disabilities. But one of the things that we've noticed is intellectual developmental disabilities over the last 2, 3, 4 decades has started to include definitions for mental illness. Mental illness generally comes with a genetic predisposition. But personally, myself, I believe in the diathesis stress model. The diathesis stress model says, yeah, you have a predisposition for mental health, but there are some types of triggers within the environment that really kind of set it off. But what we've noted was there are more people now who are being diagnosed with intellectual developmental disabilities, and we can take autism, for example, that also have mental health issues or may actually have a diagnosis of mental illness. I'm going to say may have, because oftentimes people who have that diagnosis of IDT don't have the communication skills to tell them what's going on, or someone may perceive that they don't have the communication skills to do it, and therefore may say, well, they can't have mental health issues. But what I've noticed personally is more and more kids are coming in that have autism and also have concurrent mental health issues such as anxiety and depression. Those are the two big ones that are really presenting, especially since COVID. In 2020, things just got turned on end. That is, schools weren't acting like schools normally were. So what we've noticed over time is the incidence for mental health issues for people who have intellectual developmental disabilities has continued to go up. So we want to get back to how values and kind of what are our values and how do they serve as the foundation for this course. The main value that we want to stress, is we want to include individuals with intellectual developmental disabilities, even those folks who they say, you know what, cognitively, they may be having issues, or communicatively, they can't tell us exactly what's going on. But those folks need to be involved in all aspects of their lives. And so we want to include this person. We want to make sure they're included in the pre-crisis stage, during the crisis, and post-crisis. So they're getting information, they're able to tell you, and maybe we've got to come up with an alternative strategy for them to communicate to us as to what's going on, what their perceptions are. So we want to involve them in all aspects of it. We also want to involve them in their self-care plan. So we're going to talk about, well, what are some of the options that they have? And when we get into this post-crisis intervention especially, say, well, what happened during it? And what are some of the choices that people can make so that we can try to minimize or prevent any more health occurrences from happening? So we want to empower individuals with intellectual developmental disabilities so that they have self-determination, because that leads to improved quality of life. That leads to a better life for them. That leads to a better life for their family. For me, I really think we need to expand our unit of analysis from just an individual with developmental disabilities to include their family. Their stresses come out in family issues as well. And the incidence for parents who have individuals or support individuals with IDD is actually even more so than the national average for divorce. So let's involve them, let's involve the family. Okay. Let's talk about future planning. Okay. Because when they can plan, then we can start to say, how do we change things? How do we get off this trajectory? How do we de-escalate rather than continue to escalate into a crisis situation? And to do that, we want to be proactive. We don't want to be reactive in that we see the crisis going on and we start to shout at them and say, hey, you just need to calm down. Hey, you need to give us information. You need to tell us what's going on. That doesn't work. Instead, let's be proactive. Let's talk about what are some of the ways that we can help this person de-escalate. What are some ways that we can help them communicate exactly what's going on so that we can mitigate the situation and we don't end up in a full-blown crisis. So for us, all elements of crisis planning are person-centered. They're based on this individual. What works for this individual works for this individual. It doesn't necessarily work for all people who have autism or all people who have intellectual developmental disabilities. They are unique, and so should their crisis planning. We need to assume competence to engage. We need them to be able to tell us what's going on. We need to find strategies that allow us to assess exactly where they are and their perceptions of how things are working or how things are not working. What are some of the barriers? So let's figure out how to do that. And to do that, we need to kind of take that point of view that we're going to talk about strengths rather than weaknesses. Oftentimes when people talk about individuals who have IDD, they say, hey, here's the weaknesses. Here's what happens for people who have autism. That's not necessarily true. And we can take the opposite point of view. That is, we can talk about, well, what are the strengths of this individual and how can we use those strengths to help us in our crisis planning? How do we use those strengths to help us in getting ready for the next issue? There we go. So moving on, what we want to do again is get back to, well, what actually does a crisis look like? Again, I'm coming from a behavioral point of view. And I'm going to say, well, for me, a crisis is said to occur when a person is feeling threatened, right? They have a sudden loss or change, maybe in their routine, maybe in their life, right? And they're to a point where they cannot access skills or resources that help to mitigate it. So behavior oftentimes is an attempt to meet a need, right? It serves as communication. We got a lot of folks that they are aggressive towards others, and that's their way of telling you to go away. In fact, a lot of people say, well, that's maladaptive behavior. I don't believe it really is maladaptive. It's very adaptive. Because if I'm aggressive towards people, they tend to go away. For me, I know if I'm aggressive towards people, maybe as vocally, verbally, I'm aggressive towards someone, maybe I should have slept better that night before. And when I'm tired, when I haven't slept well, I want people to go away simply so that I can get my nap. So it's true for individuals who have communicated issues as well, and behavior comes out as that way to communicate. So if we see repeated problem behaviors, right, that is repeated problem behaviors. That's not necessarily a crisis. A crisis occurs when it overwhelms the system, when the supports that are there cannot help mitigate that situation. So someone being aggressive, well, that may be considered behavior. But if they're walking around, if they're threatening to hurt themselves, if they're threatening to hurt others because they hear voices or something along those lines, then we got to say, is this reaching that threshold of crisis? And again, this is an overview. When we get into the specifics of the individuals you're working with, that's going to change because it's going to change by different individuals. So this is kind of that overview in terms of what a crisis is. Some of the risk factors for having a crisis or behavioral mental health crisis is generally these are related to predictable or unpredictable life events. So if you lose someone, that is, let's say your father dies, that can be a predictable event. That leads to other issues. It's stressful. Or simply being in a restrictive environment. Right? So like for the individual who got pulled over by the police, who could not answer the questions, if they've cuffed him and they took him down to the station, that actually may be a traumatic event that will forever change the way they perceive interactions with individuals who are first responders. What we want to try to do is, can we find those events? What are the ones that are predictable? Or perhaps there's something that's just, this is novel, this is different. So what's there? And does that person perceive this as stressful to the extent that it goes beyond the capacity and it leads to a crisis situation? So what we're hoping to remember, crisis can be a perception, it can be an experience, causing intolerable difficulty that exceeds their ability to cope effectively. That interaction just isn't working. Perhaps I was aggressive to get you to go away and you didn't go away. In fact, You approach me, you ask me questions, which I didn't understand, and you put handcuffs on me and you took me to a police station. Right? I had different people. I had a flood of all of these lights and sounds that are coming in. So we want to get to where we can start to identify what those risk factors are. So throughout here, what we're going to do is we're going to throw these quiz questions out there just to make sure we're checking in, we're making sure everybody's doing okay. So based on the previous information I just talked about, what would you say is the best answer here? That a sudden or unexpected instances of unusual behavior indicating a possible crisis could be A, treated by a psychiatrist, B, and yes, if you could, put it in that chat. Celeste is going to monitor that, and I'm going to take this as an opportunity to hydrate.
So far, we have one bold person. There's two.
Oh, there you go.
Answers are coming in now. Now people are getting a little more confident and looking good. Awesome.
Appreciate those answers, and you're right. This is based on that values, right? How do we get that? Let's talk about what are some of those medical conditions that may be there, right? We may have individuals who have a medical issue that actually comes out or exacerbates their feelings and gets them to a point where they get into crisis. UTI can actually lead to hallucinations. So one of the things we want to do, well, let's talk about what are some of the medical conditions that underlie that. So, doing okay on time? Right. So, hopefully you all know this. You've lived enough life that you recognize there are situation conditions that can lead to crisis. Right? Past experiences are one of those. In fact, traumatic past experiences often lead to future traumatic experiences. You relive that trauma, and that can actually be that trigger that sets off a next mental health crisis. So, past experiences, your interactions with others. You may all have that one friend that, you know what, sometimes when I hang out with that one friend, I don't always make the right choices. And those past experiences may come up again and again and again. Quality of life is another big one. Right? Your health, your comfort, any kind of relationships you have with others, and happiness. And in fact, individuals who have IDD oftentimes don't necessarily have the best quality of life. Okay? Many of the people that are working with them, well, they may consider them friends, but do they have friends outside of that? Or for many of the individuals I was working with who had autism in classrooms, oftentimes weren't invited to the prom. They didn't get to go on dates. And that was stigmatizing, and that was traumatic for them. And they did not value or did not see their life as having a quality of life. So they wanted to change it. Right? And that's up to us to figure out, well, how do we help them have a better quality of life? We want to make sure that they can actually participate in activities, that they're able to go out and involve themselves. Do they get to go to karaoke? Maybe there's a faith-based situation where they want to go to church, or they want to enjoy some kind of concert or event, community event. Do they get that? Right? Oftentimes people underestimate their ability to go to those events and to enjoy those events, and therefore they don't offer it. We want to change that. We want to change our expectations and say they have not only the right to do that, but they have the ability to do it, and let's make it happen for them. So another risk factor, immediate environment. Right? What surrounds them? The time of day may lead to issues. There may be certain days of the week that are tougher for others. I had worked with an individual, and he every Friday wanted to have potato soup. And they actually had put him on a behavior plan. When he had a good behaviors for the week, he got potato soup. But you know what happened? If he didn't get potato soup on Fridays, then we got into crisis mode. He went beyond just behaviors. He went beyond aggressive because he had had potato soup for the first 45 years of his life every Friday. That was part of his routine. That was part of his culture. That's where he grew up. So they had potato soup on Friday. They had a hee-haw on Saturday. And if either one of those were interrupted, then we knew we were going to have issues. Some other environmental events that may be out there. And actually, maybe this is the chance to open it up. Why don't you all tell us, what are some of the environmental events? What are some of the quality of life factors that are out there that may influence people you support? Maybe I threw the curveball there. They didn't expect that.
What was the question again, Mark? So that
What are some of those risk factors that they experience for individuals they support that are out there, either past experiences or what's in the environment that may lead to behavioral issues, which may lead to crisis? Weather, power outages, exactly. Sometimes when it's raining out there and you've got the, was it, if you hear it, fear it, if you see it, flee it kind of situation. So we're in Brevard County. There is the most lightning strikes of any county in the US, I believe. Changing living situations.
Being here in Texas and not really knowing there were floodwaters that were coming is really terrifying. Changing living situations is in the chat.
Yep.
Right. You know, no matter what people say about a move, even if you're excited about it, it's going to cause a lot of extra stress.
Can. Yeah. Getting a new roommate, right?
Mm-hmm.
Transition from high school. Yeah. What's the expectation post-secondary? What happens after high school? Fire drills. That is a great one, right? Loud noises, flashing lights, right? Maybe some people you're not normally interacting with show up. So artists, yeah, you guys are on the ball. You got it. Those are all those things that we're talking about. And just to go back to the weather real quick, that was one of the things that I found with Florida is during hurricane season, right? Because we have two seasons. We have hurricane season and not hurricane season. During hurricane season, when the weather changes, routines change, right? The environments may change. They may say, hey, you have to leave your house and you're going to go here to this shelter. Now, a lot of the shelters don't necessarily know how to support individuals who have significant support needs. And so things change a lot, and it may actually exacerbate, it may lead to a situation that gets beyond what can be controlled for. Mental health is another one, right? Once individuals reach those late teens, early 20s, that's when a lot of mental health issues come into play. But for me, one of the other big ones that's out there is, I gotta say, if you're a middle school teacher, my heart goes out to you. I salute you for your service, because I think a middle school teacher is one of the hardest things to deal with, right? You've got students who are getting hit with hormones. They're having mental health issues that are there. They're having social issues that are coming about. They have this whole thing called locker time, where you're going out from one situation into another situation, right? So you're going out from a classroom, from a teacher that you may like, into the hallway, and you've got to deal with people socially. And that can lead to stress, and that could lead to even past experiences. There are folks too that medication changes can lead to issues. And so when the medications are changed, or perhaps they need to be changed, that can become a risk factor for them having a mental health, behavioral health crisis. All right. So again, giving you an overview in terms of triggers, because Celeste is going to go into this in great detail in the next one when we talk about pre-crisis. But to kind of get you the idea of, well, what are some of those factors that are there that can precipitate or can trigger a crisis? You brought up some of those, right? Lifestyle challenges may be one of those. Having a roommate come in, right? Or going from living at home during high school to having some kind of apartment situation. So medication challenges that can come into it. Seasonal allergies, right? If you can't express that I'm having seasonal allergies, my head is killing me, is really hurting, and you can't communicate that effectively, that can lead to other behavioral issues, which can lead into crisis. Those environmental stressors, which you guys brought up, right? Having the fire alarm go off, right? I mean, even the fire drills, I really hated those because it was one of those, you just want to put your fingers in your ear to make it stop. So what are some of those other environmental stressors? So for me, it was going to the mall, right? Going to the mall, that's just one of those environments that there's just too much stimuli coming in. I wanted to avoid those situations. Especially if I had medication challenges, that is, if I don't have my certain level of caffeine, it can be a bad day. So I want to make sure that even those kind of things, right? Most people don't think about in terms of caffeine being medication or being part of pharmacology, but it is. And it can lead to headaches. It can lead to other issues to get there. Any kind of interpersonal stressors, if they have staff people working with them, roommates, coworkers, or parents. I think that's one of the most difficult times for parents too, is when your kids turn into teenagers and you try to disentangle what is teenage behavior versus what is some other behavior, what is a mental health behavior, what are some of these, and they get intertwined and it gets really, really hard to disentangle those different issues. So at times, I'm sure I've been a stressor for my kids or staff, roommates, whoever's working with them. Physical pain, stressors, again, if I don't have enough caffeine, I'm going to have a headache. Headaches lead to me having pain, which may then precipitate or trigger a more behavioral event, right? Which could lead to that as well. But again, trauma begets trauma. When individuals with intellectual developmental disabilities put in situations that are traumatic, that can be a trigger for the next incident. So if they had, let's say they were in a classroom situation, they had a fire drill, the sounds are going off, the lights are going off, and people came and they restrained them because they were acting out, that trauma could lead to the next one, because the next time those lights are going off, or even in a similar situation, the lights are going off, that can trigger trauma, which can then trigger a future event. So, some other factors associated with crisis. First and foremost is the diagnosis of intellectual disability in and of itself, right? So if you have an intellectual developmental disability, so like I said, some of those signs, some of those symptoms that are part of the categorization of having IDD is a communication issue. So if you have a hard time communicating what's going on, that can be a factor that's associated with crisis. The same with any kind of mental health condition that's there, depression, anxiety, and if I have both a diagnosis of intellectual disability and I have a mental health issue, that is, I'm anxious and I'm unable to communicate my anxiety, then those factors can lead to crisis. Then we got environmental, right? Birth of a sibling, having a little one that's there. For our kids, we had one that she was very excited about having a baby sister for approximately 4 days. At the end of 4 days, she's like, okay, you can take her back now. You've got a newborn in the situation, that you've got diapers being changed, you've got lots and lots of sounds, your parents are changing their routine. Divorce is another one that can do it, right? starting schools or transitioning and you got brought it up because you're on the ball, right? Starting a new school. Oftentimes when I talk to parents, they talk about the transition from elementary school to middle school and middle school to high school as causing anxiety for them because they're afraid their kids are going to get picked on, that they're going to be bullied. And sometimes those kids are, right? Going into middle school, going into high school, there's a whole bunch of different social situations that are going on that they hadn't experienced before. It can lead to bullying. Right? Bullying can lead to trauma. Trauma then begets more trauma. The whole concept of puberty, adolescence, and early adulthood, that in and of itself is a factor that really should be or has been associated with crises. Again, you've got hormones coming in, you're not really sure how to deal with it. So take that into consideration. Any kind of changes in residence. So having a new apartment, or like we said, going from living with their parents to their own apartment. Social relationships, right? Dating, sexuality issues, those are factors associated with impending crisis. I had an individual who had autism spectrum disorder, was going into his final year, his senior year of high school. It was the first time that he actually showed any interest in girls, and he didn't really know how to deal with that in a positive way. So he thought it'd be really good to keep talking to this girl who he thought could be his girlfriend, and he would bring it up. And at first she was very, very nice, but it became too much for her. And at some point in time, she's like, I just need you to back off. And he didn't understand what that meant. And in fact, her dad ended up calling the school. The school said, we have to have some kind of intervention here. And it really was, he didn't understand the social ramifications of trying to be someone's girlfriend or boyfriend. You get other relationships, coworkers, roommates, right? I'm sure some of you may have some coworkers that just, sometimes they just get on your last nerve. You want to change it. Right? Sometimes that coworker is your boss, and there's certain things you can't say about that. Other community members, some that are living next door. I've got one that, oh yes, I got one neighbor that I'd be very happy if he just left the neighborhood. He has a way of getting on my last nerve. So are there other life events, right? Those that may be unique, individualized. And again, when we get into those future sessions, that's really what we want to get to, is we want to start talking to you all about the people that you live with, that you support, that you love, and what are the unique individualized factors that are associated with crisis for those people. So back to the knowledge check. Can you define 2 environmental triggers for yourself or a person with IDD whom you support? What are some of the ones that are out there? Triggers. Can you? Yes, put your ideas in the chat box, and if you want to, click some factors. Maybe there if you want to think about communication issues.
So when a favorite friend moves from the neighborhood, so true. That's something you might remember the rest of your life when it happens. Exams, always. Vacations. Okay, vacations are great. They're so fun. What's wrong with taking a vacation? Except,
It
right,
can be stressful.
packing and getting there, and then your travel doesn't work out like you expected because of layover. Any change in routines, of course, especially for our individuals we support who have autism spectrum disorder, it may be even harder. Changing classrooms, so going up a grade no matter when, right? 5th to 6th grade in the same building, or absolutely teachers changing.
Yeah.
Mm-hmm.
think that was one of the issues I ran into too. We had a client who his teacher went on break for family medical leave, and they got a new teacher. But that change was a big one. Change service providers, homework, yes. So I'll leave it up to Celeste. She's going to check over those. She may add some of her own because I know she's got some as well.
Homework time. Well, sure. That'll do it no matter what age the
Right.
person is. Change in routine, unexpected situation or noises, changes in housing, changes in service providers. That's hard on both sides, isn't it? How many times have you thought, I wish I could stay their pen pal and keep in touch and find out how they are down the road, but we really usually can't do that either. I'm sure that's really difficult. I don't have the ability to like react to your comments like by putting hearts and hands and thumbs up, but just know that it's there and I'll try to comment. But these are great comments from y'all. Hey, Kristen can do it. See, she just had to, I wanted to like individually. Thanks, Kristen. You're the best.
I think I can too.
Changes in housing.
Yeah, it just comes in one. It's kind of interesting too, because I'm assuming everyone that's out there is from Florida, right? And no one brought up traffic. Oh, right? Because for me, that is a trigger, especially if I'm on I-4. Going from I-4 from Orlando out to Tampa, that can either, I've been where it takes me a little over an hour to where one day it took me 6 hours. 6 hours on I-4 did not make for a good day.
I'm aware of that commute and I concur.
Yes. And then you factor in the weather as well. That's another one. Weather and traffic. So anyway, if you're behind me, please just remember that phrase, bless his heart. What we're going to go with. So why do some people with intellectual development disabilities and mental health issues, why are they more vulnerable to crisis? And we've gone over these some, but they oftentimes experience disability-related factors that increase the vulnerability to those behavioral mental health crises. And that big one, I think, is that difficulty with verbal, nonverbal communication. Our expectation is that if people are going into crisis, they can tell you why, and they can tell you their perceptions of what's going on. That's not often the case for someone who has IDT. That is actually one of the hallmarks of having an intellectual development disability is at times they have difficulty with communication. Are there alternative communication strategies that they can use? In fact, I found that for many of my students, I've got students who are in the undergraduate level, and right now they don't even use words. It's all icons. And that's the way they communicate. At times, I have difficulty interpreting what those icons mean, as I'm still not really sure what was it, fire, pair, or something like that. I'm not sure what that means. So if you know what it means, please put it in the chat so next time I can interact with my students more effectively. I did recently learn about Skibbity Toilet. So that was a fun one for me to learn as well. The social isolation associated with intellectual developmental disabilities, right? At times, they are higher risk for abuse, for neglect, exploitation, for bullying, social rejection. All of those factors are there. And again, part of that relates back to the communication. Sometimes they are targeted because they don't have the communication skills to tell others that this is what is happening. There may be some skill deficits. Some of those skill deficits may manifest in terms of social interactions. Do they have the ability to understand when the conversation needs to end? I spent years and years and years trying to teach people how to start conversations, and when they started the conversations, I realized I never told them when the conversation is over. Right? And should there be some kind of cue there to say, okay, thanks, I'm leaving now, or something like that? What if that's not part of the skill set that I teach them? So how do we put those in there? What are some of the skill deficits that they have, or better yet, what are some of the strengths that they have, and how can we use those to build skills? There are oftentimes difficulty in life conditions, right? More than 50% of individuals with IDD live in poverty, right? Almost more than a third don't complete high school. And historically, more than a third are not employed full-time, or only a third are employed full-time. That means 2 out of 3 are not employed full-time. And oftentimes what I've seen is even if they do have a job, it is a job. It's not necessarily a career. It's not necessarily going to lead to something. And oftentimes they are underemployed. That is, they may be bagging groceries, and they may be bagging groceries for the next 20 years. Right? They don't get to move up like other folks do. So, yes, at times you're right. Sometimes those jobs don't have benefits. They don't have vacations. They don't have time off. What we found too through our research is that individuals with IDD have reduced access to quality health, and especially mental health care. That is, what we found is intellectual developmental disabilities is one system, the mental health system is another system, and oftentimes they're siloed and people don't necessarily talk between them. And it's hard to get someone who has an intellectual developmental disability to get help for mental health issues. That is, if they have depression or if they are anxious, how do they get someone to help them with those issues? So, but even healthcare is an issue. Had individuals that we're working with that hadn't seen a dentist in over 20 years. When they did see the dentist recommended that they pull all his teeth, which they did. And about 2 weeks later, after he had had all his teeth pulled, the state decided that they were no longer going to support him getting dentures. And so he didn't have a good quality of life, right? He had pain that was related to the tooth. He had other issues related to that. And at some point in time, he now had to have all his food put into a blender so that he could drink it through a straw because he didn't have teeth. Quality healthcare is hard to find for many individuals who have IDD. So those are some of the risk factors that come about. So one more quiz answer. Many individuals with IDD and mental health conditions face difficulties describing their own mental health and well-being due to, again, this is what's the best answer, because there may be multiple answers there.
We have a lot of people who are clearly paying close attention to the information you're presenting.
Yes, and ignoring our communication challenges, our inability to do the icons, let them know, thumbs up.
Very good.
Very interesting too. Everyone except Elizabeth decided to go with the capital A too.
We will accept that.
Yes. Yes. Some other things to talk about: stress and emotions, right? Social situations can provide constant or near constant stress, right? For a lot of people. I am not that social butterfly that people may think I am. I prefer to be alone. I like that, right? And when I'm put into social situations where I need to talk to people that I don't know or I barely know, that can cause anxiety. When it gets to the point again where it overwhelms is where we need to start to say, how do we identify it? When do we know if Mark's having issues today? I can see his stress levels going up, and we need to find a way for him to de-escalate, for him to cope with it. At times when people are stressed and with their emotions, others may misinterpret those actions of others. If you're in a social situation and you're trying to escape, someone's blocking the door or is in the door and you just want to get out of there and you kind of push your way through there, people are like, oh, that was rude or that was confrontational. Others may even say, well, that was truly aggressive. That person being aggressive, they push me. Rather than thinking, well, maybe it was a situation that was there and this was their way to get out. Especially if I have a communication issue where I can't tell you, I just got to get out of here for now. So it may be interpreted by others as confrontational, aggressive, or right, it may be interpreted as excitement. In a social situation, if I'm anxious, people may look at it and think, wow, he's really excited today. He's really going at it. What's going on? And it may actually be those stress and emotions because the way I'm interpreting them internally may not be the same way that you're interpreting them from the outside. Social situations, they have uncertainty built into it, right? Unpredictability with it. And at times that leads to anxiety. So, and on the opposite end, individuals who have IDD may actually interpret your actions as aggression or as confrontation. So you're like, hey, we need to just go interact with people. They may see that as very aggressive. So one of the things we want to get to, hopefully get to it at the end of this series, is how do we help individuals with IDD identify emotions? How do we get them to understand when they are anxious, when they're having a bad day, and how do we teach ways to deal with that emotional response and teach regulation? At times, many individuals, again, I'm going to go back to those teenagers, they have a limited understanding of their emotions, how to respond, positive, pleasant way, or dealing with painful feelings. If you're rejected socially, that can be a painful feeling that some people just don't know how to deal with it. Especially if you're first getting into an interest in someone of the opposite sex, where you want to date someone and you're rejected by that. How do you identify the emotions that go along with that? How do you come up with strategies to deal with that? So by definition, what we're going to go with, regulation for us is the person's ability to adjust their state of alertness, their energy levels and emotions to help them attain or maintain their personal goals, to meet the demands of the situation around them and gain a sense of well-being. That is, that sense of safety, a sense that I'm okay with myself in this situation. But as we've learned, physiologically, we're regulated, our brain and our body can integrate responses to the nervous system to manage the situation at time or manage the situation at hand. The opposite can happen as well, right? Physiologically, we can have too much coming in, our brain, our body can't deal with it, and we get into that fight or flight situation, right? What are we going to do? We're going to be aggressive, or we just need to get out of that situation. And either one of those can be interpreted by others differently. So genetically, many individuals who have intellectual development disabilities may be predisposed dispossessed towards mental health conditions. By mental health conditions, we're referring to any chronic disturbances in behavior, mood, thoughts, or interpersonal relationships that affects, again, this is where we get into the mental health end of things. It affects an individual's daily functioning. We all may experience disturbances in behavior, mood, and thoughts on a daily basis even. But until it gets to the level, those things affect our daily functioning, our ability to interact with others, then it gets to a different level. And that's when people start to come in and say, I see a mental health issue, or I see mental illness. So the most recent research has been establishing this preponderance co-occurring mental health conditions for individuals who have IDD. Again, this includes autism spectrum disorder with depression, anxiety, OCD, and trauma-related disorders. And oftentimes, this is really, really hard for me as a clinician. I had an individual who had autism, very classic symptoms of autism. And one of the things he did was if the door was slightly ajar, he had to get up, he had to come around, he had to shut that door. And if the door came ajar again, he got up, he came around, he did that door. So for me, I'm going, well, is this autism or is this something else? Is this OCD, right? And without having a background in mental health, sometimes you say, well, I'm just going to attribute this to autism. That's what it's like, right? They have anxiety. They don't have a way to express this going on. When in fact, it probably was some type of mental health issue. There probably was some OCD symptomology embedded within it.
It can certainly be hard to disentangle when it's an intellectual disability, when it's the mental health disorder, and what the treating either physicians or other types of therapists may say is that it's diagnostic overshadowing. And so we may say, oh, he's acting in a certain way that's aggressive. Maybe that's the autism. It's just because of the autism, or it's because of the diagnosis of, say, bipolar disorder. So it can be hard to disentangle those things. And what we are left with is determining what we're looking at. What are the exact responses that a person has to specific stressors so that we can help manage them better.
Right on. I'm trying to think of one of the younger individuals I had worked with. They thought he had an issue with his hearing. They gave him a hearing aid. And when I was looking through his social history, I noticed that he was on some major psychotropics. And in fact, what was happening was his doctor said, well, he's having hallucinations. And when they looked into it a little bit further, what they found out was his hearing aids actually had a reverb. And so he was hearing voices. They weren't matching up with when people were talking. And so he was reporting like, oh yeah, no, I hear voices. And so they actually had put him on some major drugs when in fact it was probably related back to some kind of reverb within the hearing aids. It gets really hard to interpret some of those symptoms that are going on, especially when individuals have communication issues. There is this predisposition, it's there, and again, trauma is a big one for individuals with intellectual disabilities because again, they're at risk for neglect, for abuse, for bullying. And that leads to trauma, which then can lead to more trauma. So, can you, in the chat, identify specific communication barriers commonly experienced by people with IDD that could increase the risk of behavioral escalation? Go back, kind of give you a peek at everyone else's homework. So some of those, some of the difficulties. And I'm going to throw some other ones out there that you guys probably are thinking about that you're like, oh, is this the right thing? What about social media? Right? The inability to understand social media and what's going on with it can lead to anxiety, can lead to depression if you're being excluded. Yeah.
Margaret said limited receptive understanding and inability to understand expectations. And I think that is so critical when we're dealing with complicated community environments, friendships. Navigating those waters can be so challenging. Aggression and fidgeting.
Yeah.
Mhm. So you may see aggression or fidgeting as even a precursor or early sign that there's a difficulty communicating, and then potential for escalation may present. Being unable to express feelings. Mhm. Inability to access a telephone, to text or call, and isolation. Mismatch of people's ability to send strong nonverbal cues and others to understand those cues. And the nuances of that are so complex, are they not? I don't know if anyone here has seen the peers curriculum for teaching social skills, but with teenagers, I've used it before. And there are these really interesting lessons, like how to be a joke teller and how to be a joke receiver, and looking for cues when your joke landed or when it failed. So like the kinds of things you should say and things you should avoid, and then looking for someone to maybe be sarcastic or shrug or look away from you after you tell a joke as a sign. So role plays can be so helpful for that. Such a great point, Tracy.
The inability of eloping, great behavior.
Mm-hmm.
And that's kind of the question. Well, what is eloping? How do other people perceive it? How do people think, well, why is he eloping? He's not following directions. It's a reason for it. Why are they doing it? Oh. Yeah, you guys got it, right? And I think, again, for me, it's sometimes I don't understand what other people are trying to tell me. And that inability to understand what they're saying or the social cues that are there in the environment. And other people may take my behavior and misidentify it as aggressive or rude. In fact, it's simply a misunderstanding. So, what we're advocating for is a biopsychosocial approach to assess the situations, right? So we're taking the biology of it, all these different factors. And when we talk about the biopsychosocial framework, some of the issues that come into it in the psychology and of things, right? Your memory, is it good, is it not? Emotions. That's one of the issues I have as being a male. Sometimes we find it hard to express our emotions. And I apologize if there's a male out here that's saying, well, you let it know I do great at that. I hope you do. But I think oftentimes it can generalize where it's hard to get males to express emotions, right? What are our perceptions? What are our thoughts? Different attitudes that we have toward different people, toward different situations, towards ourselves. Right? The social realm of things, right? What are the social supports that are available? I met some folks who did have IDD. They were looking for a psychologist that they could talk to about some of the issues they were having. And what we realized was they didn't have a choice in their psychologist, right? Because the psychologist that they got was the one that took their insurance. And that wasn't always the best match for what their needs were. So sometimes those social supports just don't match up for one reason or another. kind of family background, interpersonal relationships are difficult. Right? Culture plays a big role within the social realm of things. How they even approach the diagnosis of intellectual developmental disabilities is at times culturally related. There are some that say, oh, this person is touched by God, and they see it as a strength, whereas others see it as a stigma, as something that's not good. At times with the medical care, and this comes in the social realm of things, in that many parents have told us, you know what, when I go into the medical realm, when I bring my son or daughter into the doctor's office, they talk over them. They talk to me rather than talk to the person. It's really hard to help educate physicians on that, to say, talk to this person. It's their life that we're talking about here. Socioeconomic status, and it's not always just the low SES. Sometimes you get people that are kind of in the middle, where they make enough that they don't qualify for some services, but at the same time, to pay for those services out of pocket then leads to a lot of stressors on the family as well. Right? But also low SES. Sometimes it's really hard to find people to provide services if you don't have insurance or good insurance. I think at last count, the med waiver system here in Florida has an 18-year waiting list. That's a long wait to get services. Idea of physical exercise, right? Biofeedback, getting out and just enjoying life. What are the social aspects of that? Taking a walk with a friend. Is that possible? Is that built into their life? Right. Then on the biological realm of things, we've got that genetic predisposition. So, genetic predisposition towards Down syndrome, well-established fact. But also towards mental health, mental illness. The neurochemistry, and I would kick this one over to Celeste in a heartbeat, because if you want to know about neurochemistry, she is a lady to talk to. How do those different things interact? How do drugs and psychopharmacology interact? At times what we're finding, many kids who are given a drug are given a secondary drug to deal with the side effects of the first drug. And you get into polypharmacy, and sometimes there's interactions between those different drugs. What are the effects of medications? I had an individual who was taking medication, it led to constipation. Constipation led to behavioral issues. In fact, most of the medications that are out there are one of the opposite end of that spectrum, right? Either you're going to be constipated or you're going to have the runs. And so it's oftentimes like, well, which is it? Which is going to happen? And it's really based on the individual, and perhaps maybe on some of those other issues that you run into. That flight or fight response, right? Physiological responses and inability to actually kind of say, this is what's going on, here's my perception of it, and how other people may see fight or flight as rude, may see it as escapism, may see it as, well, they're just aggressive, they want to get out of there and they're going to push people out of the way. But if you take all these factors, take these realms into it, that's kind of where we're saying, this is where we want to go with. We want to get some kind of background on all of these different realms so that we can make an effective intervention for the person that you're working with. Another quiz question out there. According to the biopsychosocial framework, what are some major categories that influence physical and mental health?
It's too bad we didn't set this up trivia style and we could like have a leaderboard for the fast responders who get it correct.
Yeah.
You know, big points for McHugh and Elisa Verne.
Yeah.
Verne or Verne. Very good.
So again, you guys are right. It is A, those social, psychological, and biological factors that are in there. So, this is where we're going to kind of switch into it and talk about, well, we're going to talk about 3 different phases of a crisis. And effective crisis intervention entails that ability to not only see that, but relate to both individual and environmental context within each of those different phases. So when we're documenting our triggers, when we're developing our crisis plan, we see it as critically important to build upon those biopsychosocial approaches so that we can start to investigate it, we can assess it, we can talk about prior incidents and the different perceptions within there. But again, and this may be a little bit of a bias toward the behavioral end of things, but the approach is that we see human problems not from within the person, not inside the person, but within specific interactions between that individual and the larger environment, the ecosystem that they're in, the social systems that they're in, that's being supported for them, that they live. Oftentimes you see people and they're like, you know what, that person is aggressive, or that's a bad person. And the question is, could you just flip that just a little bit and say, you know what, perhaps you're perceiving those behaviors as aggressive, or as those behaviors as being unwanted. It's not necessarily the person is a bad person, but some of the behaviors that they engage in are behaviors that you wish wouldn't happen as often.
One of the most powerful talks I've ever seen, a TED Talk, was by a man named Pat Fryman, Dr. Pat Fryman, F-R-I-M-A-N, No Such Thing as a Bad Boy. And I highly recommend that for anyone who's really struggling with dealing with problem behavior that may present real challenges, because he talks about how there are no bad boys. He works for a place called Boys Town in Nevada, and it's where kids who have been through incarceration, juvenile detention centers, et cetera, have been, because it's like their last stop. And he talks about how there's no such thing as a bad boy. There are bad situations, bad contexts, bad circumstances. And that's where we have to start, from a place of love and respect, to figure out what is happening in the environment that's building these problematic behaviors that we're seeing.
Yep. I second that. And what I'll say about Pat Fryman too is he's one of the funniest people I've ever seen. He has a great way of bringing humor into the situation. And at times that is really critical. You are dealing with individuals who can engage in problematic behavior, can engage in aggressive behaviors, can engage in mental health crises, and you gotta find a way to see the humor in it, or you're gonna burn out. And I say that a lot to my students, especially when they're starting out, or special education teachers, those first couple of years, it's gonna be rough. You gotta find a way to see the humor, to see the light at the end of the tunnel, or you're gonna burn out. And you're gonna go, I could get the same money and I can go work at McDonald's. I don't get bit, I don't get hit. So I'm gonna change it. So we're getting into understanding the 3 stages, and here are our 3 stages. We've got pre-crisis, we've got during the crisis, and we got post-crisis. So we want to break it down into these, and we're going to go through each of these individually and kind of talk about it. But as I said, the next series, we're going to go over 3 more. One's going to be on pre-crisis, one's going to be on what do you do during the crisis, and then what are some skill sets that you may carry over into post-crisis, so that we can get into prevention, if we can get into mitigation, so that we don't end up with the same traumatic events, with the same mental health behavioral issues. So for pre-crisis, this is that first indication of symptoms. Again, these are typically triggered by an event. Some of them are seen, some of them are unseen. But for some of those that are seen, it could be a stressful demand. One of the individuals I had worked with, he, if his mom asked him to mow the lawn, he would do it. If stepdad asked him to mow the lawn, it got into fisticuffs. And part of it was the stepdad presented it as a demand, go mow the lawn, versus mom who also had a history of being a little more reinforcing than the stepdad, but she would not put it as demand. She would put it as a request. Would you please mow the lawn? And sometimes the way those events are phrased may make the difference between behavioral escalation or not. There may be persons or events that remind you of past trauma. Okay. So there may be individuals, like we said, who had an issue in the past with first responders, and then that led to them actually having a traumatic event just from seeing someone of that. And one of the ones that I ran into was, I think it was in Asheville, North Carolina, where they had first responders that were going to scenes where people had overdosed. And one of the things they did was when they went into the situation, they turned off the sirens, they turned off the lights, because the sirens and the lights could actually trigger different events. Right? It could actually lead to traumatic events, but it also could lead to seizures. And so when they did it, they actually said, when we go into the situation, here's what we're going to do. Or what about a response to a loss, right? Like you said, someone said, my friend moved out of the neighborhood. Had a client here who had autism, who was late teens, early 20s. And one of the interventionists who had worked with him, his favorite behavior analyst that had worked with him, died prematurely. And there really was no way to gauge that loss for that individual, right? Because people are like, well, is it just because this person's not there? Do they understand that they're not coming back? Or do they understand grieving and how to grieve and what's okay or what's not? And oftentimes people say, you know what, this is the way you should grieve and this is the way it has to happen. And that's not true. Right? And it's the same thing with crisis, especially the post-crisis. It doesn't have to happen one way. You need to observe those signs to know where you're at within that situation. Are there early signs that can be observed by a friend or family members, right? We're hoping that we can get you trained to that point, that for you as a clinician, for you as a friend or as a family member, you can start to see either internal events, right? You notice that someone starts to be a little more anxious. They start to touch their face, right? Or they may see pacing. What are those signs? And can you observe it in this stage, that is in the pre-crisis? Before we get to crisis, can you, as a family member, as a friend, as a coworker, as a support agent, identify some of those internal or external events that are happening? So that's what we're going to try to do within pre-crisis. We get into during crisis. So this is where the train's gone off the rails, right? Things are happening and it's gone beyond the system. It's no longer capable of keeping it under control. Well, what we have to get to is to a point where we understand that the individual themselves may experience crisis differently than our perception, but it's also going to vary from one person to the next person. The way I experience crisis is going to be different from the way Celeste experiences crisis. Right? And at times, when they get into the crisis situation, it's going to be difficult for them to function or conduct regular activities. They're overwhelmed. They've got symptoms, they've got stress, there's just too much input coming in. So hopefully during the pre-crisis, we can identify when things are starting to go off the rails. But when we get to crisis, and there will be times where crises are going to happen, then we want to be able to match our responses to that individualized supports need, to the individual's supports need, what they need, right? What are their strengths, what are their skill sets, and how do we match what we're going to do to their skill sets. And during the crisis phase, this is when action needs to be taken. Right? Ideally, it'd be during pre-crisis, that is, we'd be able to stop it from escalating. But when it's in crisis situation, we need to have action, and hopefully we know what that action is. We've talked about it, we've identified it, and we said, here's what we need for this individual. Because those responses to the crisis, those actions that we're going to take will vary from person to person. It's going to depend on the support systems in place. It's going to depend on the strengths of that individual, right? But also the environment that's there at the time of the crisis. What's there? What are the stressors? What's available to de-escalate? How do we do this? So pre-crisis, and we've got during crisis, and then our third one is post-crisis. So post-crisis is the escalation has happened, we're down, we're starting a little bit of calming. Sometimes when people go into crisis, they end up in more restrictive environments. They may be institutionalized, they may be in a hospital situation. This is after that situation. Or after the crisis has started, but before they're released from the institution, before they're released from the hospital, you start to convene everybody and say, let's identify what happened. Let's identify what some of those triggers were, what were some of the signs, so that we can mitigate it in the future. And what are some of the supports that we're going to need in place when this person gets out of that situation that they're in now, whether it's in a hospitalization situation, whether it's in an institutional situation. So during post-crisis, this is when the person receives the treatment and support, and we start healing, right? And again, we need to take a more broader perspective of the individual. It's not just the individual that's there, it's the whole team, it's the family, right? Our unit of analysis needs to expand beyond the individual themselves and talk about other people. It may be people in the community that were hurt during that crisis. It may even be those first responders that are there, right? Do they need to debrief? Do they need to talk about what they witnessed and how can they start to heal as well? So during this stage, it will vary wildly and very widely, depending on the crisis, depending on the situation, right? There is no set time limit for the post-crisis recovery. We can't say it's going to be a week, it's going to be a month. It depends on the individual, it depends on the support structure, it depends on the situation. But we're hoping that we can get to a post-crisis situation where it's a time of rest, it's a time of building upon the strengths that the individual has, that the team has, and connecting with the resources that are needed to prevent or mitigate any kind of trauma associated with the event, and start to say, let's identify what happened, what the perceptions were, and how we can change things in the future. Or if things went wrong, why did they go wrong? How do we make sure that those things don't go wrong again? So that's our post-crisis. All right, so during which of those three phases? The reactions or triggers may be first observed by family members or caregivers. And again, you may say, well, it could be this or this, but we want, what's the best answer? And again, keywords here are may first be observed.
Okay, McHugh is the buzzer beater again with the immediate response. We'll take that.
They didn't even need the prompts for the right answer. They had.
I feel like our kids today would say, you ate today. You ever heard that one? That means you were prepared. All of you, you're prepared. You ate today.
Got it.
Be great. So, whenever we talk about the development of a crisis situation and we try to figure out how to help people troubleshoot, I think it can be so hard to sound like we know exactly what's happening. And I think you've made a really great case, Mark, for looking at the biopsychosocial model, understanding the person. And I think it's just so important to say that y'all that are in the audience, you that are observing, who support people with disabilities, are really at the center of helping that person by identifying what you observe, when the changes occurred, what was happening right before, during, and after, so that in that post-crisis stage, if you do end up in a crisis, you're able to meet with others, perhaps the person included whenever possible, and figure out how to strategize and do better in the future at detecting things earlier. No one can tell you we know what to do in every situation. It's so individualized, but we do have some tips and strategies to at least help be better at documenting, reporting, and modifying. Great answers to the question, Mark.
That's why we're trying to get there. All right. I think we're going to be a little bit early on this because right now we're just kind of summarize. We're going to preview what's coming up. But to go back to where we started, what we want to make sure is we talk about the value serving as a foundation for this course. That is person-centered planning, right? The person needs to be involved in all aspects of their life. And even though many individuals with IDD may have communication issues, we as support people need to find ways to allow them to communicate their perceptions, right? And how they're perceiving the situation, but also emotions, right? And what they're seeing and what they're doing so that they can actually start to identify internal cues in themselves that things are starting to go a little bit sideways. We talked about the definition of crisis. Again, crisis isn't necessarily defined as, well, it's just aggression, because I've worked with many individuals who are aggressive, but that wasn't a crisis. But at the same time, there may be other individuals you work with where aggression really is the crisis. That is the line. This person is not aggressive at all, and they've become aggressive. And so where is that definition of crisis? When do we know we've crossed that? And so that's got to come back to the individuals you're working with the support structures you're in, within the culture that they live in, right? So that you can come up with an individualized definition of crisis for that person. We talked about some of the risk factors associated with crisis. So one of those, communication. Sometimes it's hard for people to communicate exactly what's going on, especially in real time, right? And that's where we may get into that post-crisis where they can start to say, well, this is what I started to notice, right? My hands started getting hot. And that was prior to the aggression. So how do we start to identify those? What are some of those risk factors associated with crisis? Well, trauma is one, because trauma begets trauma, but also people with disabilities in general are more at risk for neglect, for abuse, for bullying, right? So those are some risk factors as well that have been associated with crisis. We talked about some triggers, right? And again, this is going to be individualized for different people, right? As I said, I could believe no one brought up being stuck in traffic. That's a big trigger for me, right? I just get out of my way. I need to get somewhere. I need to be there. I hate being late. And when people are in the way, that can be a trigger for me that may lead to vocalizations. It may lead to some nonverbal communication that I try to express to them, right? And those triggers can then escalate up. Or can I start to identify what it is, and do I find ways that I can de-escalate myself, or maybe someone else that's there can help me de-escalate? Right? We reflected on why individuals with IDD may be at greater risk. Again, lack of communication or limited communication. at risk for, sorry, I had a dog yawning in the background that just kind of threw me off there for a minute. But they are at risk for uh, having bullying behaviors, any of those situations. So some of those greater risk for it as well. We do try to put things in the perspective of the biopsychosocial approaches because most of those realms can incorporate pretty much all the different issues that lead to crisis. Right? And it's that interaction of them. Right? It may not be just the biological predisposition towards mental health that leads to it. There may be some environmental cues on there, or it may be the cultural approach that they're dealing with that leads to there being an issue. And so we want to take all aspects of that biopsychosocial approach and start to put that into words, put that into descriptions so that we can get to that pre-crisis, crisis, and post-crisis interventions, right? Which are those three stages: pre-crisis, during the crisis, and post-crisis. So, and I've kind of alluded to this again, but we've got 3 more modules coming up. During those 3 modules, we're going to talk about strategies for preventing a crisis, right? Identifying what those triggers are and how do we identify those triggers so that we can try to prevent a crisis or at least help mitigate it so it doesn't get to that level where it is a crisis. It may just be a behavioral incident. What are those considerations when planning for a potential crisis? So how do we take the information we know about this individual and put it in a workable form that is portable, that can be used? We start to say, I'm seeing this behavior, I'm seeing this emotion, I'm seeing this happening. We need to start pre-crisis intervention, or we're in crisis now, and here's what we need to do. Right? What are those plans? What are those tools to employ? So one of my favorite stories that was relayed to me was an individual who was in a Western state, and they were in the ER because they were having a behavioral crisis. And it kept escalating because people kept asking her for information. What's going on? What's happening? What's your insurance number? What's this? And do you know there's going to be a copay and all this? That was not helping to de-escalate. And as part of their plan, they had a psychologist that had a background with this individual. The psychologist came in, sat down with them in the ER and said, tell me about your goldfish, right? Everybody else that was looking on was going, what is this guy doing? But talking about her goldfish helped her to de-escalate to the point where then they could try other strategies. But yelling at her to calm down, asking her for information about what's going on was not working during the escalation. So they needed a tool to help de-escalate so that then they can get back to, well, let's get to the yellow stage. We want to stay out of red. And then we're going to talk about some strategies and the processes that we can actually learn from crisis and debriefing after the crisis occurs so that we can prevent or mitigate it from happening again in the future or getting to that point of escalation. So with that, we'll leave you with some references. I believe Celeste already put it in the chat. Yes, you can have access to the slides. They're there. The references are there. I think we did try to add a lot that are specific to the state of Florida because we're doing this in the state of Florida. So we will make sure you guys have that. References are available through there. I think a lot of them actually have some codes in there so that you can actually do it. But we would really appreciate it if you can hit the QR code again, take the post test again. This is not going to be graded. Don't take this as an exam because we know for at least one of you, exams are a precursor to behavior. We don't need that. Everything's good. This is just your chance to tell us all the things that you learned, or at least some of those things you learned today. So that's celebration of knowledge. So we got another 10 minutes or so. If we want to open up to questions, is that okay, Kristen, or?
Yeah. If anybody does have any questions or wants clarification on anything that Mark or Celeste talked about, you can pop the question in the chat and I will unmute you. And that way they can talk to you directly. If you're a little shy and you don't really want to, ask the question to be unmuted, just note that in the chat and I won't unmute you, but they'll still address it for you. I also wanted to point out again, I did put a link to the post-session survey questionnaire in the chat box as well for you all. So if you could please just take a minute, it'll look very familiar to you with a couple additional questions that provide us some feedback on ways in which you feel we can improve these sessions to make it more engaging or fulfilling for you. And I also did want to note that as a part of your affiliation with PEPSA, these slides and this presentation, as you know, has been recorded today. It'll be available on the PEPSA website. So if you missed any part of this, you'll be able to go back on their website and they'll share information about how to access it and where it'll be landing on their website, but they'll have it posted there so folks can rewatch this at their leisure. Once you fill out the post-session survey, if you don't have any questions, feel free to hop off and enjoy the rest of your day. Thank you, Tracy.
So, Kristen, can I have an ask? Is it possible if they wanted to ask questions that we could turn off the recording so that they could ask questions and feel safe in asking those questions without being recorded?